Hi, my name is Dr. Jeff Babushkin. My topic today is laser microtextured abutments. I'm going to discuss the science behind laser microtextured surface, and I'm also going to discuss some clinical applications. I want to thank Dental XP for having me here today, and for you for viewing this. Our goal in implant dentistry is to replace a missing tooth as aesthetically pleasing as possible for as long as possible. And we need to concern ourselves with the area where the prosthesis exits the gum tissue all the way up to the tip of the papilla. So this is the area of concern for what I like to term a bioaesthetic stable result. So we need this result to last a long time. We need the soft tissues to completely fill the embrasures, the gingival embrasures. We need the free gingival margin position to be at the same height as the contralateral free gingival margin. We need the tissue color, contour, texture to be the same as the contralateral tooth. Laser microtexturing has been around for a while. It was developed at NYU by Dr. Jack Ritchie, and it works on a principle of contact guidance. And what it does is it's a cell-specific sized microchannel that is fabricated by the use of an eczema laser and a comb masking process where they ablate these microchannels into the titanium surface. And these microchannels are a specific size and depth, and they're cell-specific for fibroblasts and osteoblasts. This was the first laser lock implant ever placed. It was placed by a friend and colleague of mine, Dr. Kerry Shapoff, and I had the privilege of restoring it over 13 years ago. And you can see this radiograph was taken within the last 4 months. And what we noticed over time with these laser microtextured implants was that instead of losing bone down to the first thread, that the bone actually stayed in position and began to condense. So we had this condensing, almost like a lamina dura at the crest of bone without loss of bone. And when you don't lose bone, the soft tissue remains stable. So here it is, almost 14 years later, and you can see the papilla still fills, the free gingival margin position is good, and the gingiva looks as it did 13 plus years ago. So how does a tooth and an implant differ? Well, we know the periodontal ligament exists in a tooth, and what the periodontal ligament provides a tooth that an implant doesn't have is, one, it provides adaptability to stress, and secondly, it provides a blood supply to the very thin labial plate. The second difference that has been noted between a tooth and an implant up to this point was the dentogingival fibers. And the dentogingival fibers on a natural tooth embed into the cementum as Sharpie's fibers, and they provide a biological seal around the tooth to prevent bacterial infiltration and disease. And it acts as a line of defense. An implant up to this point had circumferential connective tissue fibers that encapsulated the prosthesis and a hemidesmosomal long junctional epithelial connection. In 2008, Dr. Ron Nevins up at Harvard did some research on this laser lock microchannels and found a true connective tissue attachment to the implant surface. The first time he had ever seen an implant with a connection to the soft tissue. And what he also noted was that this connective tissue attachment inhibited epithelial downgrowth and preserved the coronal crest of bone. So it gave us stability, a biological seal. Here's what the microchannels looked like on the top of the implant. And you can see they're non-randomized, specific depth and height, to prevent epithelial migration and to provide a surface for connective tissue attachment. This is what it looks like when the connective tissue fibers embed onto these laser microchannels. Again, under polarized light, you can see the orientation of these fibers running perpendicular to the surface of the implant, so they're embedding directly into that laser microchannel, providing a seal, not unlike what a Sharpie's fiber does for a tooth. So what about this critical implant abutment junction that exists above the laser microtextured surface? Well, this implant abutment junction has been implicated as a reservoir or a septic site for bacterial infiltration. It's the site of micro movement and increased stress concentrations, which has all been determined why some implants lose bone down to the first thread. They've been implicated as factors. So today, what we do have available to us is, what if we move this laser lock collar above that implant abutment junction? And we get this connective tissue seal above that septic reservoir, the implant abutment junction. Well, these laser lock abutments came out about 1.5 years ago, and there's 4 varieties of them. The one on the top left is called the aesthetic abutment. To the right is the simple solutions. The lower left is a tie base, and then there's a millable laser lock abutment. In 2010, Dr. Nevins did a study utilizing foxhounds and moving the laser lock collar onto the healing abutments. And he had 4 groups, all randomly blast textured surfaced implants, half of which had a machine collar and half did not, and half of the specimens received laser lock microchannels on the healing abutments and half did not. So there were 4 groups, group A and B having laser lock healing abutments, group C and D without laser lock healing abutments. And these are the implant placement. They were all placed at the crust of bone, and these half of the healing abutments were machined and half were laser locked. And their findings were very impressive. For groups A and B that had the laser lock collar etched onto the surface of the healing abutments, they found functionally oriented connective tissue fibers, no long junctional epithelium. It stopped at the first thread of the laser lock. And in some of the specimens, they actually found de novo bone growth above the implant abutment junction. In the groups that did not have the laser lock microtextured surface and had machined healing collars placed, they found fibrous tissue encapsulation, connective tissue fibers running parallel to the surface, surrounding or encapsulating the implant, the healing collar, a long junctional epithelium, and bone loss down to the first thread. Very compelling. And there's the bone loss. So let's talk about some clinical applications for these abutments. First, the aesthetic abutments. These abutments are pre-contoured with a scallop. They have a 1 millimeter laser lock collar, a 0.7 millimeter laser lock collar. They come in different cuff heights, 1 and 3 millimeter and 3 and 5 millimeters. And they also have an angled, a 15-degree angled abutment. The protocol for these aesthetic abutments are to be placed either at stage 1 at implant placement or at the uncovery. Now in my office, that's not how I use these. For me, it's not practical to place the final abutment the day of surgery. There's too much soft tissue that needs to be contoured with my provisional, and I feel far more comfortable doing that with a screw-retained provisional. So here's how it works in my office. Let's look at Cassandra. Cassandra presented with a fractured tooth number 9. The tooth number 9 was vertically fractured and the segment was displaced mesially. That diastema she had was actually between 8 and 9. After the consultation about whether she wanted to change that diastema in the final restoration, she described that she felt that that was part of her appearance and she wanted to maintain that diastema. So I sent her to Carrie, who extracted the tooth, and he saw this defect. Now you see the size of this defect and the size of this space, the edentulous space. So in order for Carrie to be able to place an implant into a site, here's the healed ridge, we must first fabricate a surgical guide. The surgical guide will allow the proper placement of the implant in all 5, I like to call, instead of tridimensional, a pentadimensional positioning of the implant. The mesial distal placement, the facial lingual positioning of the implant, the apical coronal positioning of the implant, the angulation of the implant, and the thread timing so that the flat comes forward. The patient disappeared for 2 years. Came back with this healing collar placed. Upon removal of the healing collar, you'll notice that the tissue is a perfect circle. There was no custom healing abutment used at this time. So the first step would be to start to develop the soft tissue contours. And to do that, I fabricated a screw-retained provisional, which you see here. This is the first attempt at the screw-retained provisional. Patient was quite happy. I left it somewhat short so that it wouldn't engage the lower incisor. She returned 4 months later. And there you see the soft tissue at 4 months. Certainly more of a pyramidal shape rather than a circular shape or triangular shape, more like what a central incisor should look like. So at this point I placed my laser lock aesthetic abutment to place, and I scribed where I wanted the gingival margins to be placed. You can see I just kind of chunked out a rough form, placed it on a prepping handle, and then prepared to mill out what I wanted that and smooth the finish lines to the proper contour. And here's the final aesthetic abutment contour. We then took the provisional and we fabricated custom transfer coping. I placed it on an analog that was partially embedded in stone, injected around it some clear bite registration material. You can see the well that replicates the exact dimensions of my provisional. Placed the open tray transfer coping to place and injected around it some flowable composite and cured it through the clear bite registration material. Took that to the mouth, screwed it in, and you'll see a little blanching. That's because the tissue slumps when it is not being held by a tooth or a provisional. Radiograph to verify proper seating of that custom transfer coping. And I fabricate a model. In this case, I'm actually going to scan this and fabricate an Emax restoration in my office using my Sura CAD/CAM machine. So here's the aesthetic abutment on my model. This is a scannable stone. Fabricate my Emax restoration, start to develop surface texture and contour. Now I have a problem here. This is a healed site. There's no bleeding. For a laser lock microtunneled abutment to have any chance of having connective tissue attachment, it needs a blood clot. It needs to become a bleeding site. So what I do is I go in with a pair of diamond and tipped cotton pliers and I start scraping away the non-keratinized sulcular epithelium until it bleeds. I make a bleeding ring of tissue above the implant fixture. And there you see the bleeding. I then place my aesthetic laser lock abutment to place. right into that bleeding site. Torque it down, radiograph to verify that it's seated, and in this case I cement retained my Emax crown that I fabricated in-house. And you can see the result. Patient was quite happy with the result. Came back 3 months later for me to do an evaluation and check. And look at the soft tissue healing. This does not probe more than 1 millimeter at this point. That implant was placed 2.5 years earlier. You can see there's no dieback of crestal bone. And look at the soft tissue, speaks for itself. The simple solution abutments are much like the snappy or the APIs that other implant companies have. They come in 3 collar sizes, 0.8, 1.8, and 2.8, and 2 abutment heights, 4.0 and 5.5. Again, the protocol is to be placed at time of placement or at stage 2 uncovery. In my office, I find that rather difficult to do. They come with a restorative pack. Inside the restorative pack, they have an analog, they have an impression coping for an abutment level impression, and 2 waxing sleeves. These simple solutions are also available for Nobel Biocare implants and Zimmer implants. They also can be used with the Nobel Biocare wrench, which is different than the 050 hex supported BioHorizon screws. Here it is for the trilobe. The indications for these simple solutions abutments are flat, non-scalloped gingival cuffs, positioning when the abutment can be placed without alteration, cementable restorations, although I have done screw retained. They're contraindicated, I believe, in the aesthetic zone, mainly because of the scalloped gingival margin. They're also contraindication when the abutment requires alteration for the path of insertion. So here's a case utilizing the laser lock simple solutions. This is Stephen, and we're going to restore 2 lower implants, posterior implants, flat, non-scalloped gingiva. Again, when I removed his healing collars, he had no bleeding. So I went in there with my diamond tip, cotton pliers, scraped away that non-keratinized sulcular epithelia to form a bleeding site. Then screwed down my laser lock abutments. There they are to place. Radiograph to verify proper seating. Attempting to place my abutment level impression copings. The first one, the most posterior one, seated properly. The second one was binding on that first one that I placed, so it needed some minor modifications. You'll know when you seat these properly because you hear an audible click. That click comes from this little rim at the gingival margin. You'll also notice that there's a fin that represents the flats. This is the provisional coping that is supplied. And here are the final restorations. Individual crowns cemented over simple solution laser lock abutments. Final radiograph to verify cement removal. Here's a case utilizing the CEREC machine to do a cementable screw retained simple solutions case. Here's the restoration being designed on my CEREC machine. Here's the Emax crown with a screw hole through the Emax crown while the crown is placed on the simple solutions abutment. Contours evaluated and checked. And here it is after crystallizing and cemented out of the mouth onto the Simple Solutions abutment, brought to the mouth after this point, and screwed to place. The screw access hole was then filled in with some direct composite resin. Here is my go-to abutment for the anterior or aesthetic zone. It's the tie base abutment. And what I like about the tie base abutment is that the mating feature of the abutment to the implant fixture is titanium, but the part that comes through the soft tissue and develops the critical contours subgingivally, the mesostructure, is fabricated either from lithium disilicate or from zirconia. The tie base is 5 millimeters tall with a 1 millimeter laser lock collar. It comes with a sleeve so that when the bonding of the laser lock tie base to the mesostructure takes place, there's no bonding agent getting onto that laser lock collar. And you can see when the tie base is placed on the laser lock sleeve that it actually embeds within it. I like to call it a turtle sleeve. And here's what it looks like on the laser lock sleeve. So here's a case. This is Michael. He has some resorption of tooth number C, actually. This is my screw-retained provisional. At this point, the implant was placed. The screw-retained provisional was made to develop soft tissue contours. At this point, we're happy with the contours of the soft tissue, and we're going to go forward with making our final restoration. Again, I take the provisional off and I fabricate a custom transfer coping so that I can replicate that soft tissue position for my lab. Here's the soft tissue model that was fabricated from that custom transfer coping with the tie base to place. In this case, we're going to do a full contour wax up of what the mesostructure is to be. This is what it looks like on the model. And I'm going to have the lab take this and press lithium disilicate for my mesostructure. And this is pressed lithium disilicate, and this is placed on top of the tie base. The tie base gets placed on the laser lock sleeve with some PTFE tape to protect that laser lock. Some wax is placed into the screw access chamber and bonded to place with a resin cement. Air barrier coating is placed over that to prevent the oxygen inhibited layer. And here's my final abutment with laser lock, tie base, and a mesostructure of lithium disilicate. On top of that, we're going to fabricate a lithium disilicate crown, pressed and layered, cut back and layered. Here's the full contour wax up. Here's the first pressing, cut back and layered. And look at the detail. All the lab work done for this case was performed by the Winter Lab in Laguna Beach, California, and I want to thank them for the laboratory photos for this case. So it looks like on the model from the lingual. And again, here it is to place. Now, again, this was a healed socket, a healed site around my provisional. So what we did here, again, went in and made it bleed first, removing that non-keratinized sulcular epithelium, then placing my custom abutment to place. There's the bleeding shown over the top. And here's the final restoration to place in the mouth. Look at the harmonious gingiva, full papilla fill, free gingival margin position in the proper location, color, contour, texture of the tissue, harmonious with the surrounding tissue. And here it is at full smile. So what we get from this laser microtexturing is a biological seal. And I know from doing these laser microtextured implants for 14 years now is that they do hold up very well over time and achieve what I like to call is bioaesthetic stability. Now I was on Dental XP watching Stephen Chu's very excellent video on immediate implant provisionals, a critical aspect in tissue care and aesthetics. And in part 2 of that video, he talks about adherence. And when he talks about adherence, this is an immediate provisional that he's placed on top of an implant that had no grafting. And what he's measuring is buccal lingual collapse of tissue. And what he found was when he removed a provisional for the first time or a healing collar for the first time in healthy tissue and the tissue bled, that was a sign that there had been some adherence to that provisional, some hemidesmosomal attachment to that provisional or healing collar. And in those cases, he found 4 times less buccal lingual collapse. And he talked about what makes adherence predictable to alleviate this collapse or eliminate as much of the collapse as possible. And his 4 thoughts were, first thing is, it has to be clean. So those laser microtextured abutments that I place in patient's mouth all go through the ultrasonic cleaning solution, and then they get steam cleaned with my steamer. There has to be an adequate soft tissue thickness vertically, and he says that because there's a certain zone of plaque adherence down 1 or 2 millimeters from the free gingival margin. Then he discussed surface texture, and he brought up laser microtexturing, and you can see by those SEM photos that we had of that connective tissue attachment that adherence is truly a predictable adherence. And then he discussed material selections, and for that we need more science. I was at the AO meeting in Tampa, Florida this past March, and a study by Dr. Gears and Reddy was presented which showed laser microtextured abutments and what happens when you take a laser microtextured abutment off and try to replace it back in the mouth. Well, they found that we did not get the same level of attachment the second time. And it makes sense when you see those SEM photos about all those fibers stuck to that very highly topical microfeatures of the laser microchannels. But what they did find was if you took a laser microtextured healing abutment and removed it, the tissue bled, and then placed another laser microchanneled abutment on top of it, back onto that implant, that in fact you did get attachment to that laser microtextured abutment. So the use of laser microtextured healing abutments prior to the placement of, say, a simple solutions abutment makes sense. I want to thank you all for viewing this video, and I want to thank Dental XP for having me. I wish you all the best. Thank you.